So let me start with the introductions then. So my name is Paul Taylor. I'm a professor of Health Informatics at the Institute of Health Informatics, which is one of the institutes at UCL. It's essentially a health data science institute, but within that institute, there are a number of people who are working in research in artificial intelligence. And I'm here today as the director of the Centre for Doctoral Training in Melbourne, which is an initiative which brings together supervisors working in healthcare and artificial intelligence from across different parts of UCL. Antonio, do you want to introduce yourself?
Yeah, so I'm Antonia Coote, the Centre for Doctoral Training Manager, so the administrative side of the centre.
And Ken?
Hi everyone, I'm Ken Lee. I'm a lecturer of AI in healthcare. I'm also the director of the study of the MRes, which is the first year of the CDT program.
And Pierce, do you want to say hi? We seem to have lost Pierce for a second. Hopefully he'll be back in momentarily. So what we're going to do today is I've invited Pierce to give a short talk about his research, to give you a flavour of the kind of work which people do in the Centre for Doctoral Training in AI-enabled healthcare. And then that should take around 20 minutes, and then there'll be an opportunity for people to ask questions if they're interested in what Pierce is doing and they want to learn more. And then after that, Ken and I will give a short presentation just giving an overview of what the CDT is and how it works and what it's like to be there. We've also got a couple of our current PhD students who will be on hand, and they'll be able to talk about it from their perspective. But I'm hoping we can wrap all of that up in around 30-40 minutes to give you a chance to ask us any questions that you might have, because that obviously that's the most, in a sense, that's the most important part of an event like this. So without further ado, and because we do have a lot that we want to get through, I'll hand you over to Pierce. And Pierce, do you want to take the floor?
Thank you, Paul. Let me just get organized. Okay, so hopefully somebody can wave to say that they see my screen. They can see my screen, or somebody can say something to confirm.
Yep, you can see it.
So
Paul,
Paul,
we're not seeing it in display mode. We're seeing the standard PowerPoint edit screen.
Okay. Is it in display mode now or no?
We can see it clearly. It's fine as it is. If you want.
So Paul, just as you were introducing everybody, my computer just crashed, and so that led to a moment of panic for a minute or two, as I had to kind of quickly try and force everything to reset. So hopefully we'll be able to go through things nicely now. But so really nice to see everybody. Looking forward to some good discussions and good questions afterwards. And so I thought I'd talk for 15-20 minutes about some of the work that we do enabled by the CDT for AI-enabled healthcare at UCL. I've called it Transforming Healthcare with AI, Lessons from Ophthalmology. Now, if anyone would like to get in touch with me, I've got my Twitter handle in the bottom right there. And on the last slide of the presentation, I'll also give my email address. And I do try to respond to almost all of the emails that I get. So I'm a consultant ophthalmologist at MPhil's Eye Hospital in London. So I'm a clinician, and at MPhil's I specialize in the treatment of retinal disease. And so those are some of the commonest causes of blindness in the UK and around the world, things like diabetic eye disease and age-related macular degeneration. I'm also Professor of Artificial Medical Intelligence at the Institute of Ophthalmology at UCL. And although I'm not a computer scientist, I'm not an engineer, excuse me, I've somehow found myself leading this multidisciplinary clinical research group that aims to develop and apply AI in healthcare. And one of the things we believe is that ophthalmology can be an exemplar for other medical specialties in this regard. I'm also very fortunate to be funded by UK Research and Innovation. So why is there a pressing need for artificial intelligence in ophthalmology? Now, this is something that I love to tell people from other medical specialties, because there's sometimes a perception that the eye is just a small part of the body and therefore ophthalmology is a small medical specialty. But since 2017, ophthalmology has overtaken orthopedics as the #1 busiest of all the medical specialties in the National Health Service in the United Kingdom in terms of clinic appointments. So nearly 10% of all clinic appointments in the NHS are for eyes. That constitutes nearly 10 million appointments per year. And that's a number that's risen by about 37% in the last 5 years. And so the brutal truth is that we're drowning in the number of patients that we need to treat. And unfortunately, there's some patients that lose sight and sometimes even become irreversibly blind because of delays in being seen and treated. So what I believe is that new technology and innovation and artificial intelligence may play at least some role in addressing this issue. Now, of course, when we talk about AI, that encompasses a very broad range of techniques and approaches. And so a lot of what I'm talking about is specifically related to machine learning and specifically related to deep learning. In fact, most of the work, almost 99% of the work that we do within my group is focused on deep learning for image classification, essentially ophthalmic image classification. Now, one of the exciting things for me, and I'm sure for everybody on this seminar, is the huge progress that we've had just in the last year in artificial intelligence. And so in July 2022, The Economist talked about AI's new frontiers. And I'm sure that many of the people on this call are very familiar with the advances that we're seeing almost daily, almost weekly, with these huge foundation models, large language models, ChatGPT, DALL-E, Imagen, Stable Diffusion, all of these new sort of techniques. And so it'll be really fascinating to try to be at the forefront of seeing how these technologies can be deployed within a healthcare setting. Now, I do believe that ophthalmology is one of the medical specialties at the forefront of AI-enabled healthcare. Now, of course, I'm biased in that regard because I'm an ophthalmologist, but the objective evidence for that is that in 2018, we had IDX, the company which does diabetic retinopathy screening software, and they were the first ever company to get FDA approval for an entirely autonomous AI system. And in fact, the second ever autonomous AI system to receive clearance from the United States FDA was also in ophthalmology and also in diabetic retinopathy. And that's for the company called iArt or iNuke. And what's amazing is that these are now commercially available products and are being used in many countries, many regions around the world at scale. Now, my own involvement in AI comes from the fact that back in 2016, I initiated a collaboration between MPhil and the artificial intelligence company DeepMind. And as part of that collaboration, we were able to share over 1 million anonymized retinal scans, these optical coherence tomography, three-dimensional volume scans with DeepMind, and together with them, we were able to develop a deep learning system. Now, we published that in Nature Medicine in August 2018, and it was very exciting that that was featured in the cover of Nature. And of course, this being AI, you can't escape the hype around it. And so it was, pretty exciting to get global media attention. Now, the fact of the matter is that prior to this in my career, I'd published lots of papers where I had put my heart and my soul into these papers, and they're probably read by like 5 people, by 10 people. And so very nice to get this sort of attention. But also a little bit awkward as well, because the fact of the matter is that although we believe that AI has the potential to save the sight of millions of people, it's still only in the very early stages of its application. And so it hasn't really realized that potential yet. But that's something that I look forward to trying to lead in the coming decade.
Piers,
No.
sorry to interrupt.
Yeah.
I don't think your slides are moving along.
Okay. Oh my
If you
goodness.
press the play button on the top, does that put it into display mode?
Yeah, no, I have been. Oh my goodness, it's some screw up with the computer. It's been in display mode for me for the last.
Oh.
Yeah.
Maybe we're seeing the wrong screen. I'm not sure.
Yeah, I've only got one screen, so it's something to do with the crash on my computer. Oh my god, that's terrible.
Oh, sorry.
Can you see?
We can see diabetic eye disease.
Okay, so what I'll do is I'll just move it along through here.
We're on slide 8 now. Yeah.
Yeah. Okay. So let me just. Okay. Sorry about that. So let me just show everybody what they missed then. So this was just talking about the advances and the different things, and so essentially where we are here, and some of the builds won't work exactly right, but essentially we developed this AI system that consists of 2 neural networks. And the first neural network was a segmentation network that we trained to delineate between 10 and 15 different pathologies on the scan. And then the second was a classification network. And we trained that to make the diagnosis and give a referral suggestion on the scans. Now, really a big focus of our work is not just going from an idea to an algorithm and publishing a good paper and presenting at a good conference, but actually it's about how we can get from code to clinic. And we're already thinking a lot about that, how we can partner with ophthalmic imaging companies or startups or pharmaceutical companies to see our systems deployed at scale. We're thinking about how this can link in with hospital eye services in the United Kingdom and globally. And so, for example, at MPhil, we're building a new hospital. We're going to start building that next year. And so in the design of that hospital, we're already trying to think about flexibility in the design so we can take advantage of the new pathways of care that we think that AI will allow. And really, though, what gets me very excited is the potential of artificial intelligence to bring world-leading expertise out of specialized centers like MPhil into the community and potentially into the homes of patients in the future. And we have a unique opportunity to do that in the context of ophthalmology, because we have community optometrists and opticians all around the UK, all around the world, close to where people live. And this means that we have an opportunity to really reduce the burden of chronic eye disease using some of these technologies. And we have a particular opportunity because nowadays, at least in the UK, most of these community optometrists employ OCT scanning as part of their routine eye test. And so it's almost like, imagine if you could go to your GP and have an MRI scan or a CT scan, and it would only take seconds and only cost a small amount of money. Well, that's the situation we have in ophthalmology. So that's just one example of the work that we've been doing, in this case with an industry partner, with DeepMind. But then separately, we've begun to develop a whole load of work which is just based with computer scientists and engineers from UCL, and leveraging some of the technical infrastructure and some of the expertise that we developed with our industry collaborations. And so one of these that I wanted to tell you about is a study called the ALTS-I study. And essentially, this is the idea that we can use AI as a window to the rest of the body, from the eye to the rest of the body. And so there was a paper that came out in 2018 in Nature Biomedical Engineering, and essentially showed that you could use deep learning and apply it to retinal photographs. And using that approach, you could essentially tell whether it's a man or a woman from a retinal photo. You could give a good estimate of the age of the person. You could tell whether they smoke or not from the photo, whether they're diabetic or not. You could even give a measurement of their body mass index and give a good estimate of their blood pressure. Now, this got a lot of attention at the time. And of course, you may say, well, what's the point of what's the point of that? There are easier ways to tell if it's a man or a woman than applying deep learning to a retinal photograph. But the reason why everybody got so excited is that retina specialists and ophthalmologists, you know, even though we look obsessively at retinal photographs through the course of our careers, we can't begin to tell whether it's a man or woman from a retinal photograph. And so if, you know, a neural network can detect something like that, what are the other bits of scientific interests that are locked within these high dimensional images that we can potentially begin to unpack? Now, in some sense, in many respects, it makes sense that the eye could be a perfect window to systemic health, because it's the retina is the only microvasculature that we can directly visualize. And famously, the central nervous system is an approachable part of the brain. So the only part of the brain that we can directly visualize without, you know, opening up someone's skull. And more excitingly, we can do it with OCT, so we can get micron level resolution of the different layers of the neural tissue. And so myself and my collaborator, Alistair Denniston, have coined the term Oculomics to describe the fact that if you combine advanced retinal imaging, big data, and AI, potentially you can open up this new field. Now, in terms of the ALSI study, which I've just mentioned, what we've been able to do at Moorfields and at UCL is link all of the imaging data that we've acquired at Moorfields with this national database called Hospital Episode Statistics. And we published a report of our cohort in March of 2022 in BMJ Open. So we know everybody who's had imaging done at Moorfields, who's gone on in any other part of the country, in any other hospital, to have a stroke or a heart attack or develop dementia or any other systemic disease. And we think that this is a potentially unique data set for AI. And so essentially it consists of over 350,000 patients, over 1 million linked hospital episodes, and in the first phase, about 6.3 million retinal scans. And in terms of systemic disease, we know that in this data set, we have nearly 10,000 incident cases of stroke, 12,000 incident cases of heart attack, and 13,000 incident cases of dementia. And when we compare that to other large cohort studies, such as UK Biobank, we often have 1 or even 2 orders of magnitude more incident cases than these much larger studies. In terms of the imaging, 1.8 million color fundus photographs, 1 million infrared images, and about 1.4 million OCT volumes. And so a lot of what I've been doing, you know, closely with PhD students working with me through the CDT is doing the initial processing, the initial image analysis for these, and then we're beginning to feed them into our deep learning models and our other classical machine learning models to try and predict stroke, predict heart attack, and so on. Now, we think that this could be a game changer in terms of public health, because the fact of the matter is that we know that about 80% of people between the age of 45 and 54 will attend their local optician for eyeglass checks. And whereas the percentage that actually attend their GP during that time is much, much smaller. And so maybe we can pick up some of these systemic diseases at a very early stage and intervene and, you know, prevent a lot of serious conditions. Now, in terms of my involvement with the CDT, I supervise currently 2 PhD students. So Peter Woodward Court, just to tell you, is a clinician's you know, clinical background, and he's working with me on use of generative adversarial networks on developing synthetic ophthalmic images. And then more recently, Dominic Williamson has joined us, and he has a physics and machine learning background, and he's really playing a pivotal role in a lot of the modeling that we're doing for the ALSI study. And then I'm the sort of clinical supervisor for these things, for both of them. And then we work very closely with Danny Alexander, who is a professor of computer science and director for the Center for Medical Image Computing at UCL, providing much more of the clinical or the technical and computer science and medical image analysis input. So just to finish up then, and it might be a little bit hard to properly read this given the sort of slight technical issues I'm having, but I guess I just wanted to convey in this very brief presentation that I do believe that artificial intelligence has the potential to transform healthcare, and I believe that ophthalmology will be probably the first medical specialty to be fundamentally transformed by this. And I think that it's very exciting that UCL and Moorfields, and indeed the UK as a whole, can potentially be at the forefront of this transformation. And then lastly, as promised, you might not be able to read it there, but my email address is p.keen@ucl.ac.uk if anyone would like to get in touch. Thank you very much.
Great. Thanks for that, Piers. If anyone wants to ask Piers a question about the work, would they like to put it in the chat, or if people want to put their hands up and we can come to them on hand? TP, you're first.
Oh, hi, Piers. Thanks for a great talk. Really interesting. So I'm a clinician by background. So I find this sort of implementation, and I work in critical care. My question is around how your experiences have been about implementing, say, an algorithm back into the NHS, and what your experience has been of that.
So I think it's a great question. It's a challenging question. I see Paul is smiling. So the fact of the matter is that I started a collaboration with DeepMind in 2015. We published a first paper in 2018. It's now 2023, and the algorithm is still not available as something that can actually be used in real life clinical practice. And so actually that just reflects the fact that to do things right is a multi-year process. You know, you have to identify your use case, you have to aggregate and curate your data, you have to train the models, you have to publish your paper, but then it turns out that you then have to do clinical trials, you then have to get regulatory approval, you then have to think of your business model, you then have to think of loads of other like sort of boring non-scientific stuff. Now we're still on course for that, but it just takes a while. And one of the things that I would love to be is able to be one of the first research groups that has really been there from the very start, from an idea to something that's used in 1 million patients or in 10 million patients. Because I feel like once we figured out the full spectrum for that, then probably we can do it 10 times or 100 times and so on. So 0 to 1 is always the hardest.
And Jamal?
Thank you. Thank you, Piers, for your presentation. I don't know if you can hear me well.
It's getting a lot of interference.
Sorry about that. My question.
I can hear you.
My question is regarding data access. You know, with Brexit, because I'm aware that prior to Brexit, the GDPR had very stringent rules when it comes to data access and being able to share data across multiple centers. So I was wondering if that has changed, and if so, how has it changed?
So I think it's an important point. And clearly, I actually have to spend a lot of my time doing the boring stuff like data sharing agreements and making sure we're compliant with GDPR. And it's the PhD students who get to do the fun stuff with the actual data. So I think we have a lot of experience in doing those things. And for researchers affiliated with UCL, in some circumstances, we transfer the data from the NHS to UCL for study there, or in some circumstances, we keep the data within the NHS and we give researchers access to it within the NHS setting. And there's various mechanisms that we can do to do that. And we're very fortunate at Moorfields that we have access to quite good compute facilities, whether it's in UCL or whether it's within an NHS setting. That's the sort of main answer. In the medium term, or maybe even in the short term, one of the things that my group has been doing to explore other options, particularly around data sharing with multiple institutions, is we've been working with startup to explore federated learning, differential privacy, all of the kind of buzzwords around privacy protecting AI, because I think that that's going to be important in the future.
So there's a couple of questions in the chat. So there's one from Hlabiwa on ethical considerations around getting information about the body from the eye. Going to take that quickly, Piers?
So I think there's some unanswered questions there. So like, what if we can predict dementia from an eye exam, but we can't do anything about it? Is that ethical? I don't think we have an answer really to that as of yet.
And there's an interesting question from Oscar about whether synthetic images from GANs can improve the quality of prediction and solve the problem of data privacy.
I certainly hope so. I think that that's an active area for research of people like Peter Woodward-Court, who's in the CDT.
Yeah. And then we should probably wind up because we've got to 1/2 past, but Suchand has got a hand up. Suchand, do you want to ask your question?
Hello, Piers. I really enjoyed your presentation. I'm really interested in the using AI on neural data to predict like Parkinson's disease. My question is, based on your experience of starting this program and going through, what would you advise for someone like me beginning such a program to be successful in it?
That's a good question. Maybe it's hard with the time we have to give some specific advice, but I would say maybe a good philosophical approach that I would tell everybody for research is try to do cool projects with cool people. And if you can do that, you'll be productive.
Brilliant. There may be more questions coming in, and perhaps we'll take them in the general Q&A if they're relevant. Anyway, thanks, Piers, for that. I think it was really important in an event like this to give people a sense of what we're doing intellectually and what the research is and where it can go. And I think that was wonderful, Piers. So what I'm going to do now is I'm going to take you through just a very small number of slides that explain what the CDT is and how it works. And then I'm going to hand it over to you guys to ask any questions that you might have about the CDT, about applying and selection and how it would work should you be lucky enough to get a place. So I'm going to try and share my screen and see if I can make that work. So are you seeing the slideshow presentation?
Yep, we are, Paul.
Brilliant. So this is a what we call a 1+3 model in the CDT. So it's a 4-year training program, and it consists of a 1-year MRes, which is a Master of Research, followed by a 3-year PhD. So you do 2 qualifications, in fact. So starting up, talk about the MRes first. The MRes, it's a master's level qualification similar in some ways to an MSc, but with a much higher project element. So a typical MSc would be 8 taught modules and then a dissertation. An MRes is 5 taught modules and then a dissertation. So it's a much larger dissertation than you would do in the context of an MSc. So just to take you through the taught element first, there's a single compulsory module that forms part of the taught element everybody does, and that's the Artificial Intelligence Journal Club. And that has a variety of functions, one of which is to get you to engage with the literature in artificial intelligence in healthcare, and a kind of broad survey. One is to get you used to the skills of analysing the literature and critiquing it and discussing it. And another one is simply to bring the group together and get people to discuss issues in healthcare and artificial intelligence once a week over the course of that MRes year. The rest of the other modules, taught modules you'll take will be a selection from optional modules offered by institutes, including the Institute of Health Informatics, but also the Department of Computer Science and others. And so you'll select modules there that complement what you've already done in your training up to this point. So for some people, they'll want to do a kind of introduction to Python programming. Others people will be ready to go in and do start at more advanced machine learning. Some of you will want to do specialist modules in areas like genetics. And we've also got on that list module in graphical models, for example. Other people will want modules that get them more up to speed in dealing with healthcare data. And so, for example, the principles of health data science covers that kind of material. We also have an option which allows students to take at least one module from another department if they're interested in that, and their education up to this point means that it doesn't make sense for them to restrict themselves to the modules on this list. So, for example, there are modules on medical image processing or more specialist areas of computer science, or perhaps in some other clinical area that people might want to take. So that's the MRes year, and that's what you do in your first year. As part of that, fairly early on in the process, you will choose a project that you will take that will be a large proportion of the work that you do in your MRes year. So we will prepare a list of projects over the summer, and we will offer those to the successful CDT students in October. And so students will then sort of look through that list, and then they'll pick a few projects that they're interested in, and they'll go and talk to the supervisors, go and talk to other students, find out about the group where that work is being done. And then relatively quickly in the first term, they'll choose the project, and then they'll go on to work on that for the rest of their MRes year, and they'll write it up with an initial project proposal coming in, I think in January, maybe a little bit later. I'm a bit vague about the precise deadlines there. But the final report is due at the end of the academic year, and that's a traditional dissertation, a bit longer than an MSc dissertation. And then after that, most students will then develop that project further for their PhD. So when you're choosing your MRes project, hopefully you will be choosing the project that you will then go on to spend the next, not just the MRes year, but the next 3 years after that, and that will be what you study for your PhD. But some people choose at the end of their MRes year to change tack and take a different project, and that's fine, so long as you're able to move relatively quickly, because you do want to get your PhD finished within the 3 years after the MRes. But for some people, it makes sense to change. Their interests might have changed. They might have, new things might come along. Sometimes it's a question of changing the supervisory team as well and moving to a different group. Sometimes it's just a question of shifting emphasis and maybe looking at a slightly different problem with some different data. But there is that flexibility. So that I've talked about the MRes year and about the selection of the project and the fact that the project generally goes on to the PhD. I want to say a little bit about the extra training that we provide in addition to the MRes and the supervision of the PhD. So we've got some themes here. So innovation enterprise, public engagement, communication skills, careers, and then some other stuff that we put into other. And we have different activities that people will engage with in the MRes year or in the first, second, and third year of the PhD. So I want to highlight here that we provide training in responsible research and innovation. This is, I think, really important for technologies like AI in healthcare, which can be quite ethically challenging. We also give people training in public engagement, communication skills. And this is in addition to the what we call the generic training, which is available to all PhD students at UCL, which can cover anything from sort of specialist computational statistical techniques to generic skills in career planning or preparing particular kinds of scientific presentations. All students get a very generous research costs budget to help them take on additional training as required. So some people will go on and take short courses offered at other universities or in the private sector. Others will use that to travel and visit partners or attend conferences or training courses outside of that. And we do encourage people to undertake training activities throughout the 4 years that they're with us. I just also want to mention that it's very important to us that you build a strong network with the other students on the program. It's an important part of a Centre for Doctoral Training that you are put in a group, in a cohort, and that you build these networks which help you build resilience, help you in collaborative work, and enable you to learn, you know, in the way that people learn from peers rather than from the sort of formal teaching staff. And so the kinds of activities we have the Journal Club I mentioned. We also have a regular seminar program. We have an annual symposium. We have an annual conference which we organise in collaboration with other healthcare themed CDTs. So that's quite a large event, which took place last year in Milton Keynes, and this year is going to be in Leeds. We have various social activities and opportunities for informal learning that we offer. A lot of this stuff has been wasn't able to happen in the way we envisaged during the pandemic. But for example, one event that we did organise during the pandemic, and I think it'll work much better now that we're able to do it face to face, is an event where we got students to work in teams addressing problems that partners had suggested. So we have a range of industrial partners we work with on the CDT, people like Microsoft, like AstraZeneca, and some consultancy organizations as well. And so they came to us and they said, okay, these are the kinds of things that are people qualifying with a PhD in their area enabled healthcare. If they worked in our organization, this is the kind of activity they'd be asked to work on. So people got an experience of working in a team and solving a problem, and also a sense of what it would be like to go on and work in one of these kinds of organizations for the next stage of their career. Public Health England, as was another partner there. And finally, just I need to remind you what the offer is here. It's a generously supported scheme by comparison with many other PhD programs. The stipend was increased last year to just over £20,000 per annum. It's tax-free. It will be increased further, I suspect, next year, but we've not been yet told definitively where it will land. The tuition fees are completely covered. And you also, as I said, get a research and support grant, which allows you to apply for up to £3,500 a year of costs for conference travel and any other costs which you incur as part of your research. So that's enough from me. I'm going to stop sharing now and invite you to ask any questions you might have about the CDT and how it works or how to apply.
Sorry, Paul, we've also got hopefully got a few existing students on the call who can give their perspective as well.
Okay, so that was Mustafa and Maria. Do you want to quickly unmute and say hi? So Mustafa, you go first.
Hi guys, my name's Mustafa and I'm in my year 1 of the CDT, and my background is I'm an ear, nose and throat surgeon, and I worked for about 10 years before deciding to do something which I would describe as definitely the best decision in my life ever, maybe second only to meeting my wife, which I'm obliged to say possibly. So it's the most amazing experience that I'm having, because basically I think there's a lot of autonomy and creativity and the possibility to learn things. If you're already from a computer science or engineering background, perhaps you already come across these concepts. And from my colleagues who on the program tell me that they've been able to speak with people who've taken their thoughts to a different level. But I can speak from my own experience, which is as a doctor. It's been so eye-opening, and I just absolutely love it. And yeah, so I've learned a lot. The structure gives that baseline level of learning and competence in the principles that one would need to go forwards, and I can also tailor my learning as well as my research project idea is starting to evolve. I can focus on certain things which are more specific to that, and yeah, I think probably the best thing is that you're deeply embedded within a unit within the CDT that has extremely strong links with all different branches of AI, basic scientists, and I feel like every time, for example, like Paul was mentioning about the journal club, whenever we have a journal club, I just think, wow, this whole other new sphere which I had no idea was involved in AI, comes up. And so I think the opportunity to do something novel from a technical aspect and from a healthcare aspect exists, and I would encourage you all to apply, because it's I think basically you can make it what you want to make it as, and I have tried not to fit it into a box of what other people have said to me, which is, oh, you do a PhD for these reasons or that reason or whatever. I just went into it and I've tried to just go to as many things as possible within the CDT and within the university, and just take advantage of being embedded within that environment, and it's absolutely incredible. So yeah, that's what I wanted to say, just from my own personal view.
Thanks for that. Maria, do you want to quickly introduce yourself?
Hi. So hi everyone, I'm Maria. I'm basically the opposite side of the spectrum as Mustafa, so I don't have the clinical background. I did a degree in computer science here at UCL. So if you have any more questions, if anyone has any more questions about UCL, I can answer those. And basically I can appreciate the other side, so all the clinical collaborations with the hospitals that UCL has, and all the opportunities that the CDT gives us. And also on a more personal level, I appreciate the collaborations even within UCL and all the departments. So my project is a mixture of the medical physics department and the computer science, and of course the CDT's department, which is the Institute of Health Informatics. Any more questions, I'm happy to answer.
So thank you both. So there's a question in the chat from actually I can't see who it's from, but the question is it possible to develop your own project ideas for possible projects with academics and clinicians at UCL? And the answer is yes. So there's two ways that works. One is that some people who apply to the program have already been in touch with an academic at UCL and already have an idea of what they want to study should they be selected. But that doesn't affect the recruitment process. So everybody applies independently of a project, and then we recruit people based on our sense of their academic potential. And then once they arrive, they have the maximum possible freedom we can give them to select a project. So we provide them with a menu of projects that academics have put forward, but we also allow them to develop their own projects, but it has to be in collaboration with a supervisor, because there has to be there's no point a student designing a project if there isn't an academic there who's able and interested to supervise it. So it has to be something of a dialogue. And in a way, the separation between projects which are initiated by the students or initiated by the academic is maybe not as great as it might initially seem, because all projects are inevitably just molded by both parties, because the student is the student's project in the end, and they have to drive it, but also the academic is there to steer as well. Another question has arisen about the timeline of the selection process. So the details of that are available on the website. We've had one round of recruitment which has closed, and Ken and I are in the process of shortlisting or longlisting candidates from that application round, who we will go on to interview later this month. And that will lead to a certain number of offers that we will make. We will have another round of recruitment, which will be the dates for which will be available on the website. And we will, again, once the deadline for that closes, it'll take us a week or two to do the shortlisting. And then once we've done that, it'll take a further week or two to get the invites to you and to give you time to prepare for the interview, and then the interviews will take place. So roughly 4 weeks, I would think, after the closing deadline, and then we will get offers out as soon as possible after that. We will try and get a list of people who we can offer places to organised as quickly as we can. But inevitably we do get people withdrawing, so we will have a reserve list as well. There's a question on if there's any further sort of comebacks on any of these questions, then do ask questions on that. So someone said, is it possible to get into the program and not get the funding? So if I understand what you're asking, then let me give an answer which I hope will give you the information you want. So our funders supply us with funding for a certain number of places. If people have their own funding from whatever source, then they can join the program as what we call an affiliate student. So we have a student at the moment on the program who has, he's a clinician computer scientist, great background, really great guy. And he was awarded a scholarship by the Thai government. He's from Thailand. And so he's able to use that money to come and participate in the Centre for Doctoral Training as what we call an affiliate student. So he's not funded by our funders, he's funded by his own funders, but he participates in all of the activities. And he does the MRes, he does a project within the CDT. If that's the situation that you were envisaging, then certainly that's that kind of thing we can support. Somebody's asked for a discussion of the interview process. It's a very traditional interview. We invite people to come and we will ask a standard set of questions. There'll be a panel of academics, normally 2 academics and an existing CDT student asking the questions. We do try and give people a a task to complete, because we think that's a more realistic basis for selection. So we ask people to read a paper and then answer questions on the paper as part of that interview process. But it's just a single stage interview. There's nothing more complicated than that. So Eden has asked a question on what are the key differences between a CDT program compared to a traditional PhD program, and how many of those who start the MRes successfully go on to the PhD program. So there are two key differences between the CDT and a traditional PhD. One of them is that it's a 4-year program, so it's a 1+3. So that the MRes year is different, and that's there to give you some foundational training to help in the transition between your first degree and possibly a master's and a PhD. The second difference is that it is it's a group of PhD students tackling this together. I mean, they're all doing individual projects, but they're all part of the same center. And that allows us to provide cohort-based activities, both in terms of training and in terms of support and pastoral support. So it's a slightly more structured program than a traditional PhD. And the question of whether students who start the MRes successfully go on to the PhD program, there is a requirement that students on the MRes achieve a certain mark to be allowed to progress, but everybody so far who's tackled the MRes has met that barrier. Some people have chosen to leave after the MRes, but that was really their choice, that they felt that there were, on reflection, there were other things they wanted to do with their life, and they'd made they'd made the decision they didn't want to carry on and do further research. Casper has applied before the deadline for round 1, but Lecker's recommendation haven't arrived. Will you still be considered for round 1? We can accept applications if the letters of recommendation arrive late, but the letters of recommendation do have to be there. So if they've arrived slightly after the deadline, that should be okay. This is a question from Ikong. Sorry if I pronounce this poorly. Ikong Yifin. On the word limit for personal statements is not specified. Okay, so people submit personal statements of variable lengths. I wouldn't do something more than 500 words, roughly a page in length, but it's not in the regulations governing the application, so you are allowed to do longer ones. If you're pending the completion of your MSc, are you still able to apply? Yes, that's absolutely standard that people will apply before before having completed their MSc. Clearly, at that point, you're not able to submit a transcript, but you can give us references, and we will discuss, for example, how you found the experience of doing with the project as interview. Although obviously some people doing the MSc wouldn't have had time to finish their projects by now, so we wouldn't be able to discuss that as an interview. But yeah, the point, the answer to your question is it's perfectly standard for people to apply to do this program while in the process of doing the MSc. Do international medical graduates need the GMC registration as prerequisite? I have no idea. I don't know if Antonio, if you know the answer to that question. That's not something that's come up. I suspect not. I'm not sure why we would need you to be registered with the GMC while you're doing the PhD, because we're not expecting you to be practicing while you're doing.
Yeah, I'm not aware of any any need either.
So Jamal has a catch-22 regarding funding. You should apply. You should apply, and indicate that you potentially have funding from your employer, and we will process your application as speedily as we can, and hopefully we'll be able to get it agreed in time. We have dealt with that situation in the past. I would not encourage you to reach out to this question from Winfrey. I would not encourage you to reach out to potential supervisors. It doesn't affect admission. There would be a certain amount of overlap between your background and the MRes, but there should be enough on the MRes for you to be able to do some material that's novel. We don't typically allow people to skip the MRes, but we wouldn't expect people to take modules which the content of which they had already covered. If you've had a paper published after submitting your application, I don't think there is a mechanism for updating applications, but if you were to be invited for an interview, you could mention this in the course of the interview. But I don't think we have a mechanism for allowing people to update their applications post submission. I understand that these things happen, but it's the same for everyone. Any further questions? We've used up the hour slot, but I'm happy to let the table run for a second if people have further questions. Antonio, are we interviewing online or face to face? Have we decided?
I assumed it'd be online still, because people are usually across the country or in other countries. So,
yeah, no, I think we'll probably do it. We'll probably do it online.
Yeah.
And obviously, it's nice to meet people face to face, but I think it's a little bit extravagant to expect people to travel to London for a half-hour interview, given that we're all familiar with doing these things remotely now. I was about to say there's a question there for Antonio, but it's not a question, it's an answer.
No, it's an answer to the question about transcripts from just earlier.
Yeah. Okay, well, if there are any further questions that people have, then feel free to address them to us. If it's around an academic question, then it would naturally go to me or to Ken. Both of our contact details will be available on the website. If it's more an administrative question or about the recruitment process, then it might more naturally go to Antonia. Anna, you've just put your hand up. You've got a quick question at the end?
Hi everyone, thank you for the presentation. Just a quick administrative question. I already applied for the program, but at that point I didn't have the transcript. So should I send in one now maybe, or wait if you ask for it?
Antonia, can you answer that?
So if admissions should be able to reopen your application portal for you to upload any information that's missing, so they'll likely be in touch with you when they do their kind of checks, and then you'll be able to upload any missing information.
Okay, but I have some letter of confirmation that I graduated with a certain classification, so maybe it won't be necessary, but okay, I'll wait. Thank you.
Mustafa, you've got a hand up?
I was just going to say, if anybody is a clinician if you need to come out of program, you need to give 6 months notice for coming out of program, which you are probably already aware of. But because you may not know if you have received a place yet, so depending on when you come out of program, whether it's August, September, or October, the 6-month window for an August rotation person is like the beginning of February. So what I did is I told everybody involved in my training hierarchy that I was going through the process, so that when I actually needed to solidify it, it didn't take a long time, because some paperwork had already been put in place in anticipation that I may get a place. So that's something that I would let you know, because Health Education England and the people at the top within your training deanery typically get flooded with requests at the exact 6-point mark. So just get it in early.
Okay, brilliant. Thanks for that. Very detailed. So Antonia's put in an email there. So do feel free to send us any questions. And thanks for being here. It was great to engage with you all. Hopefully you'll apply. Hopefully some of you will be accepted, and we'll meet again in October. Cheers then. Good luck.